Rachel, can you tell us a little bit about maintenance therapy and kind of what the current approaches are with that, sometimes I guess I'll say neglected component of therapy, what the current pediatric approaches are?
Yeah, the maintenance chemotherapy regimen that is employed by the vast majority of pediatric consortiums is a combination of 6-mercaptopurine and oral methotrexate. In the Children's Oncology Group, we've also incorporated pulses of monthly vincristine and 5-day courses of a corticosteroid. However, given that the Europeans don't incorporate much, if any, pulses of vincristine and steroid, in the Children's Oncology Group, we recently studied if we could reduce the frequency with which we give those pulses. And AL0932 went from Q4-week pulses of vincristine and steroids to Q12-week pulses of vincristine and steroids, and found that the outcomes were equivalent. So we have moved from every 4-week pulses of vincristine and steroids on the backbone of 6-MP and methotrexate to every 12 weeks. So I think that's a move in the right direction as well, sort of taking out elements of therapy that, while they're relatively well tolerated, we see a fair amount of osteonecrosis secondary to steroids, hypertension, hyperglycemia, long-term issues with obesity. That I think it's great that we can remove some of those elements that we've now demonstrated really don't have a positive effect on outcome.
Ryan, what's your approach to maintenance therapy?
It's essentially the same. Most adult ALL regimens, to my knowledge, have been used a similar, if not identical, approach. POMP is sort of the classic 4-drug acronym. Again, prednisone, vincristine, methotrexate, mercaptopurine. One thing that I've kind of borrowed to a certain extent from the pediatric experience is I try to dose adjust the methotrexate and mercaptopurine often up if I can, to try to maintain a certain level of mild cytopenias. I think the pediatricians have done a nice job studying that and showing some data to suggest that the chance of staying in remission with a strategy like that is better. So it's not necessarily a one-size-fits-all. That said, in my experience, it's not uncommon that patients have to have dose reductions, particularly early on, because they're still kind of recovering from all the myelosuppressive effects, particularly if it's hyper-CVAD, for example. Their blood counts take a while to recover. We start on mercaptopurine or methotrexate, and they develop significant neutropenia. So it sometimes takes a few months to kind of get that sorted out, but once they've recovered more, I really try to, every month or so reassess what their doses are and try to push them up a little bit. So I sometimes joke with my patients that the perfect CBC for a patient on POMP is like a neutrophil count of about 1,200 and a platelet count of about 120.
Yeah, we aim for 500 to 1,500 on the ANC with our 6-MP dosing. Are you routinely screening for NUD-T15 and TPMT genotype?
Yeah, I'm not, because in my experience, I've seen a number of patients that are very susceptible to the effects of mercaptopurine, independent of those mutations. So I find that screening doesn't necessarily pick out all the patients that I'm going to run into trouble with. So my approach is, again, I usually end up starting a little on the low end anyway, just because a lot of patients are still kind of recovering from the effects of the more intense phase of the therapy, and then kind of let their blood counts be the guide.
Rachel, you talked a little bit about late effects, and you and your colleagues have been very good about studying some of the late effects of this therapy and trying to reduce it in patients where you can do that without compromising efficacy. Can you talk a little bit about what you and pediatrics are doing in terms of addressing late effects and tracking them?
Right. I think it's been a good movement forward in the field, that people are now paying attention to what happens to patients after we treat them. I think one of the big outcomes from that is a reduction of use of cranial radiation for many of our patients. Even when I was in training, we were irradiating almost every T-cell ALL patient, even those without CNS, even some of those without CNS disease at diagnosis. I think based on our experience, but more so experience from around the world, that's probably not necessary in the vast majority of patients, and obviously has a huge detrimental impact on the patient moving forward, patients who are very likely to cure. And so, a few points reduction in your IQ isn't the extent of it. We know that they have, higher rates of depression, lower rates of employment, lower rates of college attendance, anxiety, and other major quality of life impacting events that can probably be mitigated, at least to a degree, by elimination of cranial radiation. Certainly our replacement for that of intrathecal chemotherapy, while effective, probably has some toxicity of its own that we haven't fully appreciated in the long-term setting. But I think we'll learn more about that as we've removed more and more of the cranial radiation. Other sort of long-term side effects are cardiovascular, and so we've identifying patients who may not need that induction anthracycline, I think, has been an important step forward. And then cutting out steroids where we can, I think, prevents the obesity that also contributes to the cardiovascular disease that we see in our long-term survivors. I think while not my area of expertise, there are people who have studied this very intently, and I think now that we're getting kids who are 20 to 30-year survivors of this disease, we're learning a ton about the problems that they face later in life.
Yes. Yeah.
AVN, I think the avascular necrosis, I think is particularly challenging. I have quite a good number of patients, and especially I think affects the more male than kind of the women there too, and kind of in the guys in 30s and 40s, and these are kind of particular patients that at the prime of their lives are very active, and then all of a sudden they're cured with an ALL, and unfortunately kind of dealing with they can golf or they can do other things, and they need a joint replacement. So, and I think these are challenging. So I'm actually looking forward to the day that maintenance therapy could be shorter. And I'm just kind of glad to hear about some of the COG's effort, kind of to train to some of the kind of good risk patients to kind of lengthen out the vincristines or the steroid for those patients. And then with these newer therapies and some of the cellular therapies, so hopefully we could kind of move away from the maintenance altogether maybe someday. So I think it's a big issue that we kind of don't really think about.
Yeah, I have a 22-year-old that just had to have both his hips replaced. So it's an all too common scenario.
Yeah. I would say, I think in my experience, as much as I think it's helped to incorporate some of the pediatric-inspired regimens in these young adult patients, I think the thing that I'm seeing more of than anything else really is the avascular necrosis. I would say I see a lot more of that in the patients that get those therapies because they are so heavy-handed with the steroids in particular.
I mean, so we do now vitamin D, kind of the checking. So we do everything that we can to try to prevent them. It takes a village really to take care of this type of patients. Particular social situations that young adults groups are, I think there are a lot going on in their lives there too, and then compliance with the maintenance therapy is just as important to make sure that that they get a cure. So I think but it's doable, but it takes some effort, and we have to kind of think about them and then trying to not forget about this bone health, just hopefully to minimize these complications.
There's a whole field emerging of adolescent and young adult oncology that kind of bridges pediatrics and our world. It's been very exciting to see changes in that area.